at that point, I do a 20-hour.
But you're saying this also as a man. Like
Exactly. But here's the deal. Welcome back to Longevity Lounge with Meredith Villareal. Welcome back.
Thank you. Excited to be back.
Yeah, today we're going to go deeper into what we do at our longevity clinic, Innovative Vitality. But in particular, I like to say we do 3 phases. Phase 1 is to get to ideal body weight, and that we're going to talk about. That's this episode. Phase 2, muscle mass, and phase 3 is connection and mental health. So let's and then there's also mixed in there hormones. So that's going to be peppered in there. But let's talk about what this ideal body weight is. And it's almost a misnomer, right? So tell me about your thoughts on what we do.
Yeah, I personally at the term ideal body weight just because you're more than your weight. I think that's a really sensitive topic for so many of our patients, for me personally, for anyone who's lived in this world. We're more than the number on the scale, and the scale does not represent your true health versus your body composition and your metabolic health, your visceral fat. And I think our first visits, we have patients get on an in-body scan, and I tell them, like, I'm not really going to talk to you necessarily about the number on the scale versus your fat muscle analysis and your visceral fat. Like, I think those are key points because especially women get very tense and almost triggered by your weight is this. I need you to lose 10 pounds. I need you to lose, like, we have enough pressure on our shoulders. So let's kind of skip over that talk and talk more about fat loss, muscle mass, visceral fat.
So the in-body is what we use to really look inside of you. And for those that don't know, an in-body machine is a scale, and it shoots, and you don't feel it, electrical impulses that, it's really interesting, the science of it. I got nerded out and went into it, but it shoots it in, and it uses timing to differentiate muscle as well as fat as well as water. And it uses that through the heels and through your thumbs and hands to determine total body fat as well as muscle mass. And with that, we get a lot of data, like really good
data. And it's what makes us feel comfortable, or me personally, I think, prescribing GLPs, because I know we're going to be able to tell with those, are you losing fat? Are you losing muscle? Are you actually improving your health, or are you just getting skinny?
All right. So let's go into a little bit of specifics. So ideal body weight is probably a misnomer, right? Like you said, metabolic health, body composition, so many other things. And how about how you feel in your body?
How you feel. Oh, that's perfectly said. I completely agree. I tell a lot of my patients, like, I don't even want you getting on the scale. Like, you every week are checking in with yourself. How do you feel? How do your jeans fit? Because jeans do not lie. And that's going to be enough. But how you feel is everything.
It is. Percent body fat, something I really do look at. And that is an important part, right? Because that not only tells us the muscle mass you have, but also the fat that you have.
It's true.
And for men and women, it's different, right?
Absolutely.
And I think it's really important to know that. Hormonally, we're made up differently, and we need to be made up differently. And so for men, 15 to 20% is ideal. For women, what would you say?
20 to 25 is optimal.
So and that's the goal. It's not for everyone, though.
Right. Where do you feel your best, and where are you metabolically healthy?
Right.
Absolutely is a big thing. And it's intimidating to hear that number, 20 to 25% on your first visit. I rarely even mention that because I know we get disheartened or defeated real quick, and people are ready to be negative. Like, well, I'm not going to ever hit that. Right. And it's just like, let's not even put that pressure there. Like, I know you're going to reach your goals with us if you are dedicated and, you trust me, I trust you, but I don't want you to have that pressure. But it is very good to make it clear what the optimal numbers are.
I think it's really important. That point right there, almost all of my patients say, well, in the male patients, I'm never going to get to 15%. They always tell me that. And I kind of look at them and I go, we're going to quote you right there. And I promise you we're going to work hard. And let's see what happens.
It is true.
I started at 36% body fat, 205 pounds. I'm 6 foot. And I'm at 17 now.
I was going to say, where are you
Yeah,
now?
I'm at
17.
17.
Wow. You
And
did that
I'll
more
be
than
honest
half.
with you, I never thought I would ever do that too.
Really? At
When
what point do you think that like it clicked for you? Maybe I can do this. Like how far in?
when I hit like 20%, I was like, oh my God, I got to normal body fat.
Yeah.
I've been overweight since I was like 8 years old. So, and when I went to my mentor, my doctor, she said, oh, we're going to get there. And I was like, haha, that's funny. I've yo-yo diet my whole life. But, she taught me and it was an amazing thing. So I understand when my patients say it because I'm like, oh yeah, I've been there. And I think that's really important that we've all had to go through what we were doing.
Absolutely. We understand those feelings for sure. And it's very helpful for us to relate to the patient in that manner because it is. I mean, the yo-yo dieting, like you talked about, we've done it all. I definitely went through every phase possible of calorie counting, of saying, okay, no more sugar. I'm never going to eat sugar again. I'm not going to drink any alcohol again. I'm only going to eat 10 grams of carbs a day, which is nothing. I'm not going to eat any carbs, And it's like, how long did that last? You maybe get like 3 weeks and then you're going to have a bad day and completely crash out and be like, screw that. Nothing works. It never works. And I'm going to go down that negative rabbit hole. So been there, done that.
Yeah. No, elimination diets do not work. It can't work. Okay. Let's go into, on our first visit, we get a lot of labs. We talked about that. And one of the big ones that we look at that a lot of physicians and doctors' offices don't look at is really looking at metabolic health. So there are a few things that you kind of put together from data. The visceral fat on the in-body, right? We really want that around 7?
7 or less.
7 or less.
Optimal.
And so people who are overweight are usually above that. Right. And so,
I mean, most people, even people that you would not expect, because your visceral fat is really tied in a lot with your cortisol and your stress. Right. And they've even done studies of, depression, anxiety patients where you would look at them and be like, oh, they look healthy, they look fine, but their visceral fat's elevated because that chronic stress.
That's tough. A tough thing to treat too. Right?
Oh, that's the hardest.
Right.
You can eat well and you can exercise, but to lower your
cortisol?
Stress.
Right. So we look at visceral fat. Then we also look at our insulin levels.
Yeah.
Right?
Huge.
And I think those are really important. I think we used to ignore that number because we didn't know what to do with it. Your fasting blood sugar, I see people routinely, myself, was over 100.
Easily.
Yeah.
Easily.
It's just crazy to me. Hemoglobin A1C, which is what your blood sugar has been over the last 3 months because it's attached to the red blood cell. And I think, the normals that are out there are very different than our normals, right?
Exactly. And even an optimal A1C is 5.2. And that's very rare to see, honestly. And the sad thing is your A1C, which, looks at the average blood sugar over 3 months, it can take up to a decade to show up as abnormal for pre-diabetic or diabetic numbers. And it's like your insulin resistance is building that whole time. This is why patients are fully insulin resistant by the time they finally get diagnosed.
Right.
It's just like we've had decade of time of this inflammation.
And the sad part of all of this is it's 100% fully reversible.
Absolutely.
That's the craziest thing.
Like truly can be done. And it would be so much easier to do so much ahead of time.
If you could fix your problems in your 30s, 40s, even 50s, your 60s, 70s, 80s is going to be easy.
You can go travel. You can go do what you want, how we're supposed to live a retired life.
Yes, yes. So I would say a lot of our patients who come in who are overweight, they come in saying like, hey, I need to lose weight. I've been doing this and that. And I would say about 80 to 90% of them, you'll see signs of insulin resistance, right? And what is insulin resistance? It's that your blood sugar gets to a point where it's higher because of the adipose tissue that's kind of collecting. And because of that, the insulin doesn't work as well. So it's spitting out, and this is why the insulin level is so important. All of a sudden, if you have insulin levels of 5 or 6 normal, and then all of a sudden you have insulin levels of 15 to 17, it's only because the insulin isn't working, right? So like we really need to be looking at these numbers and understanding. And the other question is visceral fat. Why is there visceral fat? Visceral fat only occurs because the peripheral fat, or non-visceral fat, visceral is just around our organs, they actually get full in the peripheral, and the body says, hey, we're full. Let's wrap our fat around the liver, the heart, and other organs. So it's and that's the most dangerous fat, right? We know that cholesterol starts to go up. It starts to get sticky. It starts to cause coronary arteries disease, stroke, all the bad things that happen that decrease our lifespan. So what are some of the things that you do to start your patients off of A, to learn, but B, as a treatment?
You nailed it right there. I mean, the patients need to understand these risks and what's going on for it really to click. And I think insulin resistance is something I'm probably addressing with 80% of my patients, if not 90. And so I explain, once we get the labs back the second visit, most of my patients were talking about an elevated fasting blood sugar and insulin, which those two components give us a HOMA-IR, which is a marker of insulin resistance. And when the HOMA-IR is elevated, I'm talking to them about picture in your body, and your pancreas is releasing a little bit of insulin. And when you're insulin sensitive, it's kind of like, for the moms out there, you're telling your kids, hey, go pick up the clothes off the floor. And when you're insulin sensitive, your kids are great. Your kids are like, we're going to listen to you. We're going to go get those clothes and pick them up. But then as they become more insulin resistant, they're like, hey, I told you to pick up those clothes. And they're like, we'll do it at the commercial break. And you're like, okay, hey, I remember I told you that last show you were watching. They're like, we'll do it the next half hour. And it's like, you have to keep releasing more and more insulin, and the cells are not responding because your kids aren't responding. And it's just like, you have to find the metaphors that click,
I love
right?
that.
And so many of the patients are just nodding their head like, oh, that sounds like my kid. And it's just, that's how life is. So making these connections that you understand on a human level, because sometimes the science is, even my head, sometimes I'm listening to lectures and I've already stopped, right? And so clicking that, and then how do we do it, right? And obviously we always talk about our pillars, the nutrition and the exercise, but there's medications too. And when you're truly insulin resistant, that's where we talk about, I know you love your metformin. Metformin's there, the GLPs, I think berberine too. And I honestly, I do not talk about berberine as much as I should.
But first and foremost, like slapping on the blood sugar monitor, right? Because and I tell patients, for the first week, I don't want you to change anything.
Yes, live
they
your life.
Always change things because they can gamify. They're like, oh, what? And I'm like, actually, eat your pizza, eat your bread,
have the cocktail,
eat the pop, have the champagne, all of it, and it actually becomes a game after a while. But 1 week, for what I do with my patients, I have them screenshot every morning, the day before, 24 hours, and I'm like, listen, I'm just gonna comment. You just tell me if you ever spike above 140, what you ate. And it's a kind of a fun connection.
Above 140 is a lot.
I know.
A lot.
But you remember, these people are insulin resistant.
That's what I'm saying. So they're fully food tracking.
Right. They are now monitoring and understanding what foods trigger it. The nutrition becomes easier to talk about. Right. Blood sugar monitoring is like the best thing that has happened.
Yeah, the data point. You're right. The data point marker people love, but behaviorally, I still remember what caused my highest blood sugar, and that was 4 years ago that we were wearing them.
Taco Tuesday? Mine was.
Yours a taco. Oh, that would break my heart now. Thank God. Mine was a bagel. Which I was eating bagels.
That would break my heart.
Honestly. And with all the great bagel places in Chicago. But that's what did it. But even though we know these things, to see that and then to see it dip and connect.
How you feel when it dips.
Exactly.
Right? Because all of a sudden on Tuesday afternoon, I would always be like, God, it's just a midweek kind of tired. Oh no. By the Taco Tuesday. And by the way, it's the pork in pineapple juice.
Yeah.
I didn't realize
that's how you
two
do it.
tortillas, and I would have two of those, and I was like, oh, this is kind of a healthy.
And it seems small.
Oh my God. I was so tired. And then what do you do when you're tired? You go get a latte, right? Vanilla latte. Who spiked it up again? It was a circular kind of craziness.
It's truly ridiculous because we have this knowledge. Like, we're pretty smart and humble, obviously. But like, even with that, we didn't connect the dots, and you need to see it visually to be like, oh yeah, an hour ago I had the bagel, an hour ago I had Taco Tuesday, and then I literally just went on a roller coaster ride with my latte, and then I'm going to have a little bit of candy. And, it's just like, we need to see that. So I love the behavioral with the data point.
So that I always start, and then let's talk about the book we make them read.
Yeah.
So Glucose Revolution, like, it's a very simple book. We can go through the 4 things it teaches us. Every health book can be written in probably 3 pages, but to make it compelling with anecdotal evidence, some science behind it, it's obviously longer, but she did a great job. Jessie and Suppy
the audio is just as good as the book.
The audio is better because she has that Australian accent. I know. Actually. She's wonderful. She's changed a lot of lives. I'm very thankful for her. At Innovative Vitality, we give that book to every patient that walks in. And I basically do a book club with them. And I'm like, for the first month, I'm like, did you read it? Did you read it? Did you read the first couple chapters? And then it is. And what she talks about, we overconsume carbs. And when I'm talking carbs, I talk about complex carbs, not the healthy carbs of greens and fibers and salads. I'm talking about pasta, bread, your bagels, my flour tortillas, and the kind of the goodies that we kind of all love, because carbs create comfort. And it's a drug. Yeah. But what that drug does to you has consequences. And not all carbs are bad, obviously. And so decrease the carbs if you can. So little things like always eat the fibers and the greens first, right?
100%.
Order of operations of eating. That's always the thing I think my patients get so excited about.
Because that's doable. Yeah. That's easy. And that fiber is creating that mesh for the food to go through as opposed to right through the bloodstream. Like, we love Bavette's. Bavette's is favorite steakhouse Chicago because it has that big publican bread. Like, that bread I dream about. And there's no way I'm not having that bread and salted butter. But it's like, I'm saving that to the end of the meal now. Just to start the meal with that. And it's like, no, let's have broccoli, and then I'm going to have the shrimp cocktail and steak, and then it's the mac and potatoes and bread.
Absolutely. And
we should enjoy it all.
Right.
It's about balance.
So how this works is the fiber, the greens, the salad, why we want to eat salad or asparagus or Brussels sprouts beforehand, is that it has so much fiber in it that then the second thing you can eat is what it pushes is the protein and fat. You put that in your stomach, and then you do your carbs, the breads, the hash browns, the whatever. And instead of spiking up, because of the fiber and the complex mesh, as you called it, are in there, it slowly goes up. So it doesn't go up as high and as quickly, and your bloodstream doesn't push out like the insulin that needs to come out.
You feel so much better, and your patients love it because they can tell a difference.
The third thing she talks about, and the Europeans, the Italians do this the best, is like after a big meal, they'll go take a walk.
The best, easiest thing you can do.
Yeah. And pathophysiologically, all that's doing is the blood sugar that's getting into the bloodstream being used and absorbed by the muscle right then and there. Boom. The muscle takes it, and the blood sugar doesn't really spike.
And it's also perfect for so many of our patients come in with complaints of bloating. And it's like, that's going to help your digestion. It's going to help acid reflux, bloating, your blood sugar. It's all connected. Yeah. And so go walk after your meals. Yeah. And you just feel better.
And number 4, and you love this more than I do, I think, is the vinegar. Tell us about the vinegar.
Oh my gosh. I did love the vinegar at first.
I'll tell you a story about you. We went to sushi with Dr. Ghazi and Meredith and I, and we're sitting there, and all of a sudden, we had only had our waters, and like the both of you, like out of your purse, take out a flask, and I'm like, what are you guys doing? And you pour a cup in there. I'm like, what is that? Apple cider vinegar. Apple cider vinegar. I'm like, what has happened?
Yeah. I mean, 10 years ago, what was in that flask? Maybe something else. Exactly. Now, what's in that flask? Apple cider vinegar.
But it's true. The studies show it for whatever reason decrease your blood sugar
Yeah.
spikes. And we were eating sushi that day. I mean, sushi, the way I eat it,
Oh my gosh.
it's
Yeah. I
like
mean, but apple cider vinegar, edamame,
yes,
and then the sushi, winning
ooh,
combo.
yes,
Come on.
it's great.
Like
It's
it's
great. And if you
perfect.
have sashimi,
Yeah, true.
I mean, like one roll, major sashimi,
Yeah.
really healthy.
Yeah, absolutely. And no spice. The vinegar does it, which is also great for salad dressing. Like,
Yeah.
and vinegar's easy.
Yes.
Delicious.
So that we do a book club on this book called Glucose Revolution, written by the glucose goddess, as she calls herself. You should follow her on Instagram as well because she's really good. And then what I like to do, especially for really significantly metabolically ill patients, who have insulin resistance, I put them on metformin. What the metformin does, it starts to decrease blood sugar spikes. And I'll do one a day for about 4 days. And if they tolerate that, I'll put them on a second one. I do 500 milligram extended release. And I would say 80% of them like actually tolerate that. Some of them have like stomach issues.
Yeah.
And then I'll go back to one if they can't tolerate it. And then I'll add berberine. So we were talking about berberine as well. And if they can't tolerate the one, I will do 2 of berberine, which doesn't have any of the stomach. I don't think it works as well as metformin. And metformin is actually a medication that you get at a pharmacy, whereas berberine is more of a supplement. And there's a little bit of variability with that. So I like the metformin. It's a treatment for diabetes, prevents diabetes, and has studies that show it prevents obesity-related cancers just as well as GLPs. So I'm a big advocate for that. What are your thoughts on it?
I think that metformin can be amazing for the right patient. I do not use it as much. It's very personalized dependent. If the patient is fully insulin resistant, they're metabolically unfit, even my PCOS, or metabolic syndrome patients, like it's perfect. If I see on a glucose monitor that blood sugars are continuously elevated, I think, it's a discussion worth having, but you really need to look at the lifestyle because data-wise, I think metformin does not work quite. You're not going to get the same benefits on super active patients that are exercising all the time, which usually aren't your fully resistant insulin patients. But from a longevity standpoint, a lot of patients come in because they've read, influencers, Matcha Molly or whoever said, get on metformin and you'll live longer. And that's not necessarily the case.
That's right.
And so I think if you're more sedentary and for the patients that are fully insulin resistant, maybe we're focusing just on nutrition first. That is a great addition. And I love the metformin. But if you're coming in and you are running half marathons and Ironman and you're strength training, you're not going to have the same benefits. And it can actually impact your VO2 max training and things. So I get worried about talking about it with my longevity patients because I feel like they've just heard through the grapevine to take it and they don't understand, you're not going to have the same benefits.
Right. It should be personalized for sure. So, all right. So at this point, we've kind of got we got the blood sugar monitor on you. We talked about the glucose revolution kind of book hacks that we call it. We really want to control those blood sugar, plus or minus the metformin. And each time we're still teaching them how to eat, but we're not calorie counting, right?
No.
We're actually just looking at blood sugar spikes.
Yeah.
And when you think about what we're really doing, it's because people are like, because a lot of them lose 50 to 70 pounds. They're like, how did we do that without calorie counting?
Right.
And it's like, well, most of your calories were in carbs. And we showed you just didn't need them.
You're focusing on the protein. You're doing this. Like, we don't have to.
We aren't dieting.
Do every little
We're literally just changing your macro composition.
Right.
And you're actually full. So that's the key. Like, you don't need to starve yourself to change your body composition, which I did not realize until I was like, 45 years old.
Yeah,
which
that
is crazy as a doctor.
Such a good point. You do not need to be starving to lose weight.
No, I had no idea. You don't even have to really be hungry. You just have to eat the right food.
Yeah, it's that simple. And I think from the macro standpoints, we talk about macronutrients, right? Protein, fat, carbs. Micronutrients would include the fiber there. But macros are what we look at, mostly the protein. And especially if it's a GLP patient, that's a whole other conversation.
Right.
And I think that's where it gets a little tough because we've had patients come in who've maybe seen a nutritionist or a dietitian or their trainer, and they've been given specific macros, and it doesn't always agree with what we say.
No,
you know?
It often doesn't. And people ask me this all the time. Why don't you have a nutritionist in there? I'm like, actually, I love nutritionists.
Yes,
but
this
if
isn't a
they were
bash.
so great, there would be no obesity, right? Like, unfortunately, it's not that easy. There's more to it than just calorie counting and macros of what you eat. There's behavioral change.
Yeah, you need to know the patient, and what happens with a lot of the appointments with maybe a dietitian or nutritionist who doesn't fully understand and know the patient the way we get to, is that you have to understand they're putting in answers that you give into a calculator and giving you pretty much a generic response. And think about how you honestly answer those questions. Because I know that 10 years ago, I was probably saying, yes, I work out 5 days a week. Did I work out 5 days a week? On my best week, but how often was that? Are you truly giving the responses? Because otherwise, they're giving you macros for someone who's training hard that often. And this is why so many people are being told, eat 180 grams of carbs and 120 grams of protein. It's like, no. We're already at failure.
And
Let's
who has the
get to know
ability
you.
to count those and all
Don't
of that?
too much.
So we simplify things and just say, hey, look at your blood sugars. Try to not let them spark. For me, I'm like, less than 140. That's it.
Yeah.
If you can keep it below 140, of course, eat carbs at breakfast, lunch, and dinner. I don't mind it.
That's not what we're saying, but it's have the hacks.
Yes, and let's not spike them, and you'll feel better. Now, one thing that I teach people, I don't make them do it, but I'm like, hey, for 2 weeks, I want you to do this. Intermittent fasting. What are your thoughts on that?
Oh, intermittent fasting is another one. Very personalized. It's not for everyone. I think that especially for the perimenopausal and the menopause woman, we have to be really careful because we do not want to send you into a higher stress situation with it. And it depends on when you work out. Because a lot of my patients are working out early in the morning, and I do not want these women going in fasted and unable to eat after the workout. So again, it's personalized. I think for some people it works amazingly. And I think GLP patients, it naturally fits in very well. But intermittent fasting can be so many different things. And I think naturally circadian rhythm fasting works a lot better as even a slow introduction. I am a lot more conservative and babyish with my patients. Like, I'm going to nurture you. You're a bit harder, much harder, and give some set rules.
So my thing isn't, I agree. It's personalized. My thing is I think everyone should learn how to intermittent fast. Whether we do that long term, totally different.
Fair.
In fact, when I get to phase 2 muscle building, I'm going to make sure you're not actually intermittent.
Okay, good. I was about to say, we're going to debate right
if
now.
you don't get your protein, you're not going to grow your muscle, right?
You can't.
So at the beginning, I'm like, hey guys, we're going to teach you. So what intermittent fasting is where you have an eating window of 8 hours, the 16 to 8 method that I'm talking about, where you have 16 hours where you're not eating anything, 8 hours where you can eat. And the reason I want people to know how to do that is simple things like, hey, I'm traveling, okay? I'm traveling at 9 a.m. I have a flight. I'm going to hit my hometown of Kansas City where I have family, and I'm going to have some lunch there afterwards, probably at 1 after I land at 11 and get, whatever, we're going to go to barbecue at 1. What if, you're at the airport, and usually airports don't have the greatest food, right? Can we train ourselves to be like, hey, I'm going to go get a plate of barbecue, good meats, maybe not lean, maybe some mashed potatoes, whatever. It's not a healthy meal, but what if I just fasted, right? I want to teach people that we just don't need to eat 3 meals a day because we've been taught that. It's like, oh, what's breakfast? What's lunch? What's dinner? It's like, no, actually, if I'm going to go to Bavette's tonight, right, bone in, ribeye.
Doing it right.
And I'm salivating.
I know.
And
we're going to need to do that afterward.
That is a feast. Bavette's is a feast.
For sure.
At that point, I do a 20-hour.
But you're saying this also as a man.
Exactly. But here's the deal. Every once in a while, when we have these special occasions where the knowledge and the ability to do it, I think is really important. And again, I wouldn't do this every day. No. Some people do it. Mark Wahlberg is famous
Okay,
or
he is in a league of his own.
right. But what is
He's in my
said
top
is like
five for
every
life. Love him.
personal, it's all personalized.
It's
And if
very
you've ever
personalized.
seen
I
his meals,
completely agree.
they're like 4 meals.
Wakes up at 2 a.m. I mean,
He also has a chef. He has a personal trainer here. He has a nutritionist in his other corner.
multimillionaire.
Right.
There's
So
peptides involved.
like our patients aren't like that, but anything's possible, right? If you
Mm-hmm.
personalize it to your own thing. And I think it just teaches people is like, oh, I'm at the airport and yeah, I'm a little hungry, but I know I'm going to get really good food. I'm going to get some water and put
some
a little electrolytes in there. And I'm going to say no to the chips or the pretzels. And I'm going to have a really good meal. And so that's what I introduce.
That's a great point. Yeah.
And also when they have the blood sugar monitor for 16 hours, flatline at 80 to 90, right? Like nothing's happening.
Yeah.
They're like, ooh, and they're like, wow, I can do that. So if people are having problems with that, I think that it shows them how, because that's our goal, right? No spikes. So
yeah. Slow rolling hills, boring day. Yeah.
Say they're 20 to 30 pounds overweight plus, and they're agreeable to GLPs, right? Because they're still trying. They're maybe doing some intermittent fasting, maybe lost a few pounds at this point. How do you approach that? The GLP.
The GLP. So the first appointment, I ask every patient, is there anything specifically you're interested in? Anything you do not want me to bring up? Because GLPs have a lot of stigma and opinions behind them. And there's patients who want nothing to do with them. And it doesn't mean that I'm never going to bring it up, but this is something I know I need to be a lot more sensitive and make sure that it is appropriate and we understand. And then you have other patients that come in that are like, can you shoot me with whatever you have today? Like, let's go. And so it's reading the patient, understanding what they want, their goals. And usually I'm not talking about anything until we have your blood work back and I see what you look like from the second appointment, health-wise. And then we go from there. I tell every patient that this is shared decision-making and nothing you say is going to offend me. If you decide you want to go one route or another, it doesn't bother me one way. I'm fully invested. This we're doing together, but I like to present everything. And I do think GLP medications are game-changing. They're life-saving. They're just fantastic. I have so much praise towards them. And so, and there's a lot of patients that come in understandably apprehensive, and it's like, I'm just going to plant little seeds. Let me explain to you that when I talk about a GLP-1 medication, this is not just a weight loss drug. This is lowering your inflammation. This is treating insulin resistance. Has studies right now about, whether or not the cancer prevention or Alzheimer's or whatnot, but it's just reducing cardiovascular risk. Like, we love them.
Yes, they're a game changer.
So it's just planting those seeds to know it's not a weight thing. This is a health thing. And this is how, again, the metabolic health, 93% of our country is like metabolically unfit. This is a true problem. And we've been going about it the wrong way. And if now we can have something that can help us. And again, that stigma exists because patients are on these meds unmonitored, uneducated, and it's a free-for-all.
Right.
And our patients are doing it right.
Agreed. So, all right. So they decide, okay, I'm open to it, right? So we have a lot of work to do, right? So because we want to get this covered. It's very expensive medication. That's one of the problems. Though it's gotten relatively better.
It's definitely improved,
but it's still
needed to go down more.
Right?
Yeah.
So we're doing the prior authorizations. We have a whole team of excellent prior auth people. We know what to put in the chart. We fight. We'll do the
We are
peer-to-peer.
relentless.
Yes. And we get them for the most part. And for me, when I ask the patients what's going on, many of them still have the blood sugar monitor. First of all, they're like, oh my God, my blood sugar is too low, right? They always come in, it's never too low. I know you're afraid. It's not insulin. So I have to convince them. They're like, my alarm's going off all the time. And these people used to be at 100 are now at like 65, right? And I'm like, this is what normal is. So great. But secondly, the food noise. They talk about the food noise.
The food noise shutting off, I think, even for me personally, when I first started a GLP-1 medication, that I had not anticipated. And you go back in time and realize how much food has ruled your life. Like I was waking up in the morning thinking, what am I going to have for breakfast? And then when's my next meal? And the second I finish a meal, I'm thinking about my snack. And especially as somebody who was calorie counting and doing my MAC, I was obsessed. And I didn't think I was obsessed and I didn't think it was unhealthy. But when that food noise is silenced, you realize I have the whole day ahead to complete other tasks. Like, what am I going to think about?
I mean, they're talking about GLPs as a treatment for disorderly eating.
Yeah.
Which we were always worried about the opposite, right? And it's that food noise turning off. And you now more than ever before use food as energy instead of pleasure.
Right. This is your fuel. This is what can I eat now that's going to keep me feeling good throughout the day? That's not going, when you wear the glucose monitor, you realize those spikes to crashes, and you can just be so mindful with your eating, which is how it's supposed to be. And I have multiple patients with chronic binge eating disorder, and this has saved their life.
Yeah. Now, not all greatness, right? One of the biggest problems that we see with patients that do not get educated when they're on the GLP is muscle loss, and it's talked about a lot. Yeah. So tell me what you do for your patients to prevent that.
So there is a whole hour spent with my patients before a GLP is even touched. And I instill a little fear about this muscle loss, or my patients are even more worried than I am when they do their first in-body check-in, like, what's my muscle? And I love that. That makes me really happy. But I explain that I think a big issue with the GLP-1s that is because people aren't educated enough on them is psychologically, you take this med, it turns off the food noise and you feel good. But these patients start to starve themselves easily because you're not hungry. You're not thinking about food. They're not fueling. They lose weight, though it's muscle. And they start to see what they think are positive results and think, oh yeah, my appetite was the enemy. Food is the enemy. Right. And that's not it. And they're starving themselves without feeling hungry. They're losing muscle, but they start to gain back hunger down the road, and they're like, oh no, this is a problem. And hunger wasn't the problem.
Right.
And that's where I really make it clear that I want you to enjoy your food. I want you hungry. I want you eating a full meal and fueling properly. This is helping shut off that other noise that is saying, I'm going to have another cookie and let's have some pizza tonight. And you just don't want it.
And I think what's great about the way we do it, and we use a lot of what's from Atomic Habits, right? Which is a book about building great habits. We started all this without the GLP, right? They came to us and we taught them how to eat a good amount of protein and decrease the carbs. And so we started that with the blood sugar monitor as their guide, where they don't need us there all the time. They just have to look at their app and be like, oh, I messed up, right? And then all of a sudden, you've turned off the food noise with the GLP. And then they're like, oh, it's so much easier to eat the greens and the protein and very little carbs. And they do the glucose revolution hacks. And it's, and the weight just keeps coming off. And to your point, when you're talking to them about not having muscle loss, they have to get their protein in.
You have to get your protein. And the first phase that we talk about is, with fat loss. And in our society, we're very like cannonball in. So patients come in that are like, I started here and I hired a trainer and I'm going to cut out all sugar. And it's like, let's just focus on blood sugars, protein. I don't even need you lifting crazy weights yet. I don't want you running. I want you to focus on the foundation of nutrition, not protein alone.
Right.
Especially because most people are not eating enough protein. So once they do, the muscles build. And it's like, that's exciting enough.
And you brought up a great point. It's like, people are like, okay, what should I do at the gym? Right when I start, I'm like, nothing. No, don't do that.
We'll get there.
And they're like, wait, you're the only doctor who says don't exercise. I'm like, no, we got to get our nutrition back. And by the way, growing muscle and losing fat at the same time, you need at least 10 to 11 hours of sleep every day. You're going to be sore unless you're an actor who's getting paid millions of dollars with a chef and a personal trainer, and this is your actual job. Like, let's lose the weight. Let's do a little bit of exercise.
Yeah, bonus points
But
if you can do this, but don't put that
I
pressure
don't need a
on yourself.
PR for your pull-ups right now.
Yeah.
Right. We're gonna get there, I promise you. But it'll be a lot easier
Yeah.
when you're at a weight that you like
Feel
and manage.
comfortable. Yeah, and you can see almost people just kind of like exhale. Like,
Yeah.
okay, actually this does seem a bit more obtainable now because you're not giving me 8 million rules to follow and all of these boxes I have to click. Like the nutrition has to be there, the protein has to be there,
Right.
and you'll get there.
Yeah, and it's like if you can do half a pound to a pound loss every week. I don't want. At first, sometimes it's 2 because there's like this is such a shock to the system. But you slow and steady,
Slow and steady.
and then they lose the 20, 30 pounds, and they're like, oh my god. For women, they're like at 20% body fat, and they were at 40. Right? Men, they're at 15, and they're like, oh, what are we doing next? I'm at the we got the goal that we wanted, and I'm like, here's the time we're going to do phase 2 now, right?
Game on.
Right. And that's our next podcast that we get to talk about.
My heart and soul. My
Yeah.
favorite phase.
And what I tell people is as hard as phase 1 was, phase 2 is harder.
So much harder.
Right. But people can't
So-
believe that. We never tell them that up front because they're like,
Good
oh
now.
my God, weight loss is the hardest thing. I've never been able to accomplish that.
Yeah.
But it is, but it's also using science, atomic, like some habit formation and building on the successes of
Yeah.
everything. And by this time, isn't it great? Because your patients think you are the best thing ever because you've solved
They trust you. Yeah. They're like,
solved the problem.
You got me. I got you.
Yeah. They're like, what do I do next? And you're like, good, listen to me because we're going to show you some great things.
Oh, yeah.
So, it's been so fun talking to you.
Always a pleasure.
So thank you so much.
Of course.